Good afternoon. Good afternoon. We're going to go ahead and begin our agenda today for the Committee on Health. First of all, I want to welcome. I know we have some students here from the CSU Health Policy Conference. Wave. Oh, I love that. All right. Okay. Thank you very much. Okay. You can wave, but you can't applaud in my committee. So you can do that all day long, okay? That's fine. So thank you for being here, and it's a great opportunity for you to see some of what we're doing in action. You should have come last week when we had a 7-hour hearing. No? Okay. All right. So I was here. So anyway, well, thank you for being here, and I hope you find this to be a valuable experience. So we're going to be hearing two bills today. First of all, and the first bill is a lengthy bill with a lot of testimony. We have a pretty large agenda associated with that. So for AB 1568, we have expert witnesses to discuss the components of the bill. And after that discussion, Assemblymember Bonta will present the actual bill. We will have brief comments from support and opposition. If people wish to testify on an issue that hasn't been presented, discuss concerns, or ask for amendments, then please sign in with the sergeants up in the front here. Depending on how many people sign up, we'll decide at that point how to divide up the time. After that, we'll allow organizations to state their name and position on the bill for the record. So at this point, we'd like to go ahead and get started, and we will invite up Mari Cantwell from DHCS. And we can also invite up let's see, Sarah Muller, Sharetta Lane, and Kelly Brooks. You might as well all come up and have a seat, get comfortable. So Mara, you get to lead off. You're going to be talking to us for a while.
Yes, you guys are going to get sick of me after a little bit here.
I doubt that. Please, whenever you're ready.
Sure. So Mary Cantwell from the Department of Healthcare Services, thanks so much for having me. So I was asked first, before we actually get into the contents of the waiver, to talk a little bit about how we got to where we are, and particularly with a focus on hospital financing, since that has been a major focus of the waivers that we've had. So really all of this started in 2005 when we had our first statewide 1115 waiver. And that was really triggered because CMS was looking nationally at certain financing mechanisms, and they wanted to see a change in the way that states were financing their Medicaid programs, particularly with respect to hospital financing, but not exclusively. They had essentially a basic concern that the use of what we call intergovernmental transfers, or IGTs, which is a mechanism where public entities other than the state transfer funding to the state to be used as the non-federal share to draw down federal Medicaid payments. CMS contended at the time that states were inappropriately using this mechanism to essentially get more federal money with no real non-federal share, and were essentially returning the non-federal share to public entities that were then using it for non-Medicaid purposes. So at that time, California actually had a significant portion of its hospital financing that was funded through IGTs. And so we had to go through this process of how do we figure out how to change hospital financing in California. And so with the 2005 waiver and associated changes that happened at the time, hospital financing really diverged into a three-way split. Previously, all hospitals were really paid in the same way, where inpatient services were funded with state general funds and federal funds. And then supplemental payments for mostly safety net providers were funded through this IGT mechanism from public hospitals and counties. So after 2005, when we had the first waiver, what happened is we split the hospitals really into three groups: what we call the designated public hospitals, which are our county and University of California hospitals; non-designated public hospitals, which are our district and municipal public hospitals; and then our private hospitals. With the 2005 waiver, what essentially happened was we were trying to get rid of as much IGTs as possible. And so CMS really preferred a different mechanism called certified public expenditures, where essentially the hospitals show what costs they experienced, and they would get a federal match for that. So for their inpatient hospital services, if it cost them $5,000 a day, they would get $2,500 in federal reimbursement. Essentially, all the general fund and inpatient reimbursement for the designated public hospitals was taken away and replaced with this mechanism, as well as the supplemental payments essentially shifted to mostly a CPE basis with limited use of IGTs. The non-designated and private hospitals essentially then switched from having some of their funding paid with the IGTs of these other public hospitals to being mostly reliant at the time on general fund and federal funds. And so their inpatient reimbursement stayed the same, although in later years in 2013 and 14 they changed from negotiated per diem rates to DRGs like Medicare. That essentially stayed the same, and then their supplemental payments, essentially the general fund that used to pay for the designated public hospitals, was switched to use to fund the supplemental payment programs that used to be funded by IGTs. Since then, though, there has been other supplemental payment programs that we've all talked about here, where in alignment with the additional funding that was happening through the waiver for the designated public hospitals, the programs like the hospital quality assurance fee that funds additional supplemental payments to private hospitals grew into place, and we've had one of those since 2009. So then we got to the 2010 waiver, where again we continued this process of having these divergent hospital financing mechanisms, but we were looking to do more in the 2010 waiver. So for the first time, we introduced a delivery system incentive payment program for our designated public hospitals, which was essentially a pay-for-performance program, where for certain projects and outcomes they were receiving additional payments. Also, the 2010 waiver started us on the path to the Affordable Care Act expansion. It included the low-income health program, where we did that early expansion of coverage to adults up to 138% of poverty level before the 2014 expansion. That expansion was county-based and really, again, was focused on how do we get the delivery system ready for California to successfully implement the Affordable Care Act. So we had this expansion and we had this incentive payment structure, and that continued through the end of 2015. And so we really were starting to focus in 2014 and 2015 in developing the waiver renewal that we're going to talk about today. We were really looking with the 2015 waiver renewal, how do we push even further innovation and the focus on outcomes and value? So we had done a great job in expanding Medi-Cal. We had done a great job through the 2010 waiver and really starting that delivery system transformation. How could we drive that even further? So our initial waiver proposal, which we actually talked about in this committee last year, was very ambitious, had a lot of outcomes-focused, incentive-based programs that we were seeking support from the federal government for. It was building on the work in the 2010 waiver, but really expanding that to a much broader part of the Medi-Cal waiver. We also had as a focus during the renewal that we wanted to make sure for our designated public hospitals who had relied on the waiver funding for, at that point, 10 years, that funding was going to continue in a sustainable way so that they could continue to be the critical safety net providers that they were. So while we didn't receive approval for the $17 billion waiver that we originally submitted, we were successful in obtaining a waiver that we are very excited about, with some really critical programs that hopefully you all are excited about as well as really being able to provide that sustainable funding for the public hospital systems. The renewal is for a 5-year period, started January 1st of this year, and it will continue through the end of 2020. We call it Medi-Cal 2020 to reflect the fact that we're hoping that we'll see a transformed Medi-Cal program over the course of the next 5 years. Overall, the waiver has initial federal funding of $6.2 billion over the next 5 years, and there's some potential for some additional funding in one of the programs, the Global Payment Program, that I'll talk about in a moment. There are 4 major programs that are in the waiver that I'll talk about. There's the PRIME program. It stands for Public Hospital Redesign and Incentives in Medi-Cal. It's a build-off of the DSRIP program. There's the Global Payment Program, the Whole Person Care Pilot Program, and the Dental Transformation Initiative. In addition, I'll talk about briefly at the end, there are many evaluations, assessments, and reports that we are required to conduct through the course of the 5 years. So just to provide an overview of the 4 programs, the first, again, is the PRIME program. This builds off the 2010 DSRIP program that I talked about before, which, as I mentioned, was an incentive payment structure for our designated public hospitals. It was the first of its kind in the country, and many states followed suit and have now either had DSRIP programs approved or are currently seeking DSRIP programs. Because we didn't want to be just repeating ourselves, we did change the name to PRIME to reflect that we were talking about sort of a new version of that program. We were really seeking to broaden the system improvements that started to occur from the DSRIP. So that included broadening the number of participating hospitals, requiring more robust participation standards and standardizing some of the projects and requirements, and increasing expectations for outcomes and performance, so less of a focus on infrastructure. Today, Prime is open to not only the 17 designated public hospital systems that participated in DSRIP, but is also open to all of the district and municipal public hospitals. Initially, there's $700 million a year in federal funding for the first 3 years for the designated public hospitals. That's the same amount of funding that was available in the last few years of the prior waiver. For the district and municipal public hospitals, for the first 3 years, it's $100 million annually in federal funding. And again, that's all new funding for those hospitals. For both of those groups, the funding drops by 10% in year 4 and then 15% in year 5. The hospitals have submitted their applications to participate, and they have to meet the standards that are set out in the terms and conditions of the waiver. We're currently reviewing those applications. We received 54. All 17 designated public hospital systems have submitted an application, and 37, which is almost all of the district and municipal public hospital systems, submitted as well. For the designated public hospital systems, because this is their second time going through a program like this, there's a higher level of requirements for those hospitals. There are a minimum number of projects they have to participate in, as well as specific projects that they're all required to participate in. For the district and municipal public hospitals, since it's their first time participating in this, they are able to select just one project, or they can select multiple projects if they choose, and almost all of them did select to do multiple projects. From the 54 applications that we got, 270 total projects were proposed to be completed during the next 5 years. That's a lot of focus, and we're really excited about the work that we think these hospitals are going to do. Just to briefly tell you what those projects are about. The projects are grouped into 3 domains. The first is on outpatient delivery system transformation. We really felt that it was important in this waiver, and the public hospitals agreed with us, that we wanted to focus on the outpatient delivery system, really focus on primary and preventive care, improving that delivery system so that we could get to a place where we're preventing unnecessary hospitalization and emergency room utilization. There are 7 projects in this domain, 3 of which are required of the designated public hospitals, plus they have to select an additional project. The projects that they're required to participate in include the integration of physical and behavioral health, as well as ambulatory care redesign in both the primary care practices and specialty care practices. And then the other projects that they can choose from are really prevention programs focusing on cancer, obesity, and heart disease. The second domain is targeted high-risk and high-cost populations. The goal here was to find those populations where we think there's a significant opportunity to really improve their health outcomes and really change the care delivery and reduce, again, unnecessary hospitalization and emergency room utilization. There are, again, 7 projects in this domain, 3 of which are required of the designated publics, and again, they have to select a 4th. The required projects focus on perinatal care, care transitions, and complex care management for high-risk populations. And the optional projects include focuses on foster care, health homes for foster care, post-incarceration, advanced illness planning, as well as chronic pain management. And then the final domain is resource utilization efficiency. It is what it sounds like. It's really a focus on avoiding misuse and overuse of certain drugs and technologies. The designated publics have to choose one of the 4 projects in this domain, and they're focused on antibiotics, high-cost imaging, high-cost drugs, and advanced illness and blood products. The one other piece of Prime to mention that is new this time around and was not in DSRIP is that for the designated public hospitals, there's an interest on our part and the part of CMS to really promote alternative payment methods, so really value-based payment methods that focus on sharing risk and focus on value and outcomes, so things like capitated arrangements, bundled payments, things of that nature. And so what the waiver requires is that in the aggregate, the designated public hospital systems need to have 50% of their payments from Medi-Cal managed care plans for patients for whom they have primary care responsibility be in an alternative payment methodology by January 2018, and that increases to 60% by the end of 2020. In support of that goal, there's also a requirement that each designated public hospital system have a contract with at least one Medi-Cal managed care plan in the service area in which they operate. So moving on to the second program is the Global Payment Program. Again, this is something that we're really excited about, and actually I personally am very excited about, and is unique to California, and again, something where we're leading the nation, and really looking at transitioning funding that has traditionally been focused on uncompensated care into something that can really drive change for the people who are going to remain outside of coverage and remain uninsured. Under the Global Payment Program, we're taking 2 previous funding streams, disproportionate share hospital funding, which has always been for uncompensated care for the uninsured and Medi-Cal, and funding we had under the prior waiver called the Safety Net Care Pool, which was uncompensated care funding for the uninsured. The program in the waiver is for county hospital systems, so that's a subset of the designated public hospitals. The designated public hospitals that are University of California hospitals will continue to receive DSH payments as they traditionally have. Both of the DSH and Safety Net Care Pool funding streams were cost-based over the past 10 years. And in addition, the bulk of the funding is really in the DSH funding stream, and that's strictly for hospital services. So both of those elements, the hospital focus and the cost basis, really didn't support the direction that we and the county hospital systems were really wanting to go, which is a focus, again, on primary care and prevention, even for the uninsured. So that really we're being able to provide places where the uninsured could go for primary care and not have them end up in the emergency room or in hospitals unnecessarily. But the problem was, under the former structures, if a county system wanted to do that, there was a financial disincentive. They would lose DSH funding because it was cost-based and it was focused on the hospital, and they might not actually get any funding because DSH couldn't be used outside of the hospital. So if they had non-hospital clinics that they wanted to fund, they would lose access to this funding stream and have nothing to replace it with. So that's where the Global Payment Program came into play, where we said, okay, we're going to take that funding and remove those barriers and instead create a global budget for each public hospital system, so that they could then figure out how to structure a system for the uninsured that made the most sense for them and was really focused, again, on primary and prevention and reducing things like inpatient use and emergency room use. So under the program, each public hospital system has this global budget, and they can earn that amount through providing a baseline threshold of services to the uninsured. So it's all focused on the remaining uninsured. And that threshold amount of services is based on historically the amount of services that they've provided to the uninsured. The utilization is going to be measured through a standardized way where we assign point values to services, and we've set the base point value as 100 points for a regular face-to-face outpatient visit with a doctor. And then the rest of the services are valued sort of relatively to that. So inpatient is worth more points, certain types of things are worth less points. One of the things that we did is initially the relative values were based on the cost. So again, inpatient, relatively higher cost than an outpatient visit. But over time, what we've structured is that we wanted to encourage, incentivize, and essentially require that the county public hospital systems move away from a focus on hospital services, which they were already wanting to do. And so over time, the values for inpatient, acute inpatient, and for emergency room services decline. So if a public hospital system just continued to do what it had previously done, it actually wouldn't be able to earn its full budget amount. So it incentivizes that change to focus on outpatient services and really increase the outpatient service utilization. In addition, one of the other pieces that's unique about this is that services that either previously weren't reimbursable or weren't captured or weren't really utilized are actually now valued in this point system, so that they help the public hospital systems be able to achieve their budgets and allow them to provide these sort of non-traditional services. So that includes technology-based encounters, things like e-consults, telemedicine, things of that nature, as well as other non-traditional services, things like the use of community health workers, paramedic treat and release programs, patient support groups, group visits. All of those things now will also actually be getting data on and seeing how that utilization is being used and how utilization is changing over time in terms of the services that the uninsured are receiving. The federal funding under the Global Payment Program, as I mentioned, is a combination of DSH, that would have otherwise gone to these hospital systems, as well as this prior waiver funding. In the first year, that's $236 million. So combined, we're looking at $1 billion for the first year for this program. As I mentioned earlier, that non-DSH component is subject to CMS receiving this report that we have to submit actually next month on uncompensated care. So we don't know what that level of funding will be in years 2 through 5, but we're hopeful that we have a strong argument to maintain at least some certain level of funding for that. The third program is the Whole Person Care Pilot Program, another brand new program under the waiver. This program is designed to test locally based initiatives that will coordinate physical health, behavioral health, and social services for beneficiaries who are high users of multiple health systems, as well as users of social services and needing housing as well. These are individuals who are in the emergency room a lot, in the hospital a lot, And really, we believe if you have a targeted intervention, could really improve not only their health outcomes, but their life outcomes. So these pilots will identify their target populations, be sharing data between these systems, coordinating care, and really evaluating the progress on outcomes over time. There's $300 million annually in federal funds in this program, so a total of $1.5 billion over the course of the 5 years. The public entities who would be the lead entities under these pilots would be responsible for providing the non-federal share through their own local funds. So as I mentioned, a lot of the goals really increase integration across county agencies, health plans, and providers, reduce inappropriate utilization, build infrastructure that's needed to support the type of care coordination we're talking about, improve quality outcomes, health outcomes, as well as, if this is what a pilot would like to do, increase access to housing and supportive services. We will be seeking applicants for the program. The applicants will be the lead entities, and they must be a public entity, such as a county, a hospital authority, a hospital district, public hospital. We're also in the midst of getting CMS approval to add to that list Indian health clinics or tribal entities to be able to be lead entities. In addition, the lead entity has to include certain required participating entities, at least one Medi-Cal managed care plan, the county mental health program, the county health services program, one other public agency, and at least 2 other community organizations, although we certainly hope that lead entities will be engaging the full spectrum of community providers in submitting their applications. So the applicants are going to target their populations that make the most sense for their community. And again, we're looking for high-need populations that include individuals with multiple chronic conditions, serious mental illness, high utilizers, people who are homeless or at risk of homelessness. But again, they will define that. We're not specifically requiring any particular population. Generally, the whole person care pilot payments will support activities that build infrastructure to integrate services among the entities to serve the target population, provide services that are not otherwise reimbursable under Medi-Cal to improve care, including some supportive housing components, and implement strategies that would improve integration and reduce unnecessary healthcare utilization and improve health outcomes. I know that the housing and supportive services piece is of particular interest, so I thought I would touch a little bit more on that. We weren't as successful as we had hoped in order to get federal funding for direct housing subsidies. CMS would not approve of that. But there are certain things that the whole person care pilot does allow federal funding for. That includes individual housing transition services, so services that assist beneficiaries in finding housing and obtaining housing. Housing and tenancy sustaining services, so things that can help a person stay in their home once they are in the home, and then additional services such as searching for housing, helping with moving, communicating with landlords, and things like that. In addition to that, the whole person care pilot program does allow for what we call flexible housing pools, and that's where local only funding, so no federal funding, could be pooled together to support actually direct housing. That pool could include savings that accrues to the entities participating in the program because of the interventions that they're doing, and so we are hopeful that many of the applicants will take this up as an option as well. We're still in the process of finalizing the requirements with CMS on this program. And we have shared out the draft application, draft selection criteria that is out there now for comment with stakeholders. We also continuously update a frequently asked questions document as we continue to entertain more and more questions. We are hoping that we can finalize everything with CMS in the very near future to be able to release the final application in May. And those would be due in the summertime, and then hoping to get, again, the program up and running certainly before the end of the calendar year. The final program of the 4 is the Dental Transformation Initiative. Again, really excited to have this in the waiver. It's the very first time dental has been a part of our 1115 waiver. We viewed this as a critical piece because we wanted to see some fairly significant targeted investments towards improving dental care and oral health care for children in Medi-Cal. There are 4 components of the program that I'll get into. It's focused, again, on pediatric dental, and we're testing different methods of value-based payment and treatment methods. And what it's allowing is up to $750 million over the course of 5 years, all of that to go to providers for participating in these programs and achieving certain outcomes. So the first domain is focused on increasing preventive services utilization. As we've talked about in this committee and many other committees, we are not in a great place with preventive services utilization for children in Medi-Cal. So we have a goal of increasing that by 10 percentage points over the next 5 years, and that we believe this part of the waiver will help with that. So what this is will be a statewide incentive payment program. All providers will automatically be eligible to participate. And what will happen is we will set individual provider targets based on their baseline data and targeting a 2 percentage point increase every year in preventive services utilization for that provider. And they will earn an incentive payment on top of getting the payment for the service of 75% of the rate. So essentially could get a 75% increase to the funding that they would otherwise get for providing this increased level of preventive services. So they won't have to opt into this. It will automatically happen. And we're working through some of the details still, but that is the goal, and we're excited about that. The second domain is focused on Cary's risk assessment and disease management. There's a particular risk assessment and treatment model that we will be testing. We're going to pilot this initially in counties where there's high restorative to preventive ratios. So where you're seeing the wrong thing, you want to see more preventive services. And the intent is to implement this risk management and treatment plan. So under the risk management, there's 3 categories of risk a child would be assigned to. A treatment plan would be developed from that. And then providers would be eligible to not only provide the services and get payment for the services, but then receive incentive payments for actually completing the assessment and completing the treatment plan itself. We will be monitoring the utilization codes, seeing how utilization hopefully is switching again between restorative and preventive services. In this case, dentists would be opting in to participate, and there are going to be particular requirements in order to sign up to participate to make sure that they're trained appropriately in this model before they would join. The third domain is on continuity of care. So just like in physical health care, it's really important that someone has a place to go, a dental home, to go year after year. So we want to encourage that. And so what we're looking at here is incentive payments to providers who are that for children. So there'd be different levels of incentive payments if you see a child for 2 years in a row, 3 years in a row, 4 years in a row, essentially increasing the number of years that you have the child in your service. For this, it will initially be in selected counties where we're seeing low utilization, but we would be looking to expand it across the state. Again, in this one, you don't have to opt in. Every dental provider would be included and would be eligible to receive the incentive payments to the degree that they meet the targets that are set. And then finally, the fourth piece is the local dental pilot programs. So under this, we are authorized to allow up to 15 local dental pilot programs where local communities would come together to figure out what they would like to do to focus on those 3 areas that are in the first domains: preventive services, Cary's risk management, and continuity of care. No more than 25% of the annual funding in the program, so we have the $750 million total, is available for this, so there's a cap in it in the waiver. Eligible entities would be counties, tribes, Indian health programs, or UC and CSU campuses, and they would be submitting an application to participate, and they would essentially propose how they would focus on one or more of the domains and how they would structure payments. We've been working with CMS and a stakeholder work group to further refine all of the 4 domains that you just heard me talk about and the incentive payments and participating criteria. So we have several of our stakeholder groups, including dental providers, dental plans, et cetera, working with us to really make sure that we're structuring this in a way that's going to work for our dental providers and actually have the outcomes that we're looking for. For the local dental pilot programs, we did just release a request for a non-binding letter of interest, so we could assess what are people interested in doing so that we structure those pilot programs in a way that would best serve the communities who are going to be interested in participating in them. So then briefly, in closing, I just wanted to mention that, as noted at the beginning, in addition to the 4 programs that I just talked about, the waiver also contains requirements for lots of evaluations, reports, and assessments. Lots of writing will be happening in the next 5 years. We're required to conduct at least 1, but in the case of several of the programs, 2 evaluations, sort of a midpoint and a final. In addition, as I mentioned, we have independent reports on hospital and compensated care and hospital financing generally, the first of which is due next month, May 15th. And that focuses just on the designated public hospitals. And again, that will be used by CMS to help determine the non-DISH funding component of the global payment program. Next year in June, That will be expanded to cover all hospitals, so all 400 hospitals we have in the state will be having to do this assessment for. And then finally, we have a requirement for our external quality review organization to do an independent access assessment of Medi-Cal managed care plans, looking at how they are doing it at achieving the Knox-Keene standards and other contract standards for network adequacy, including a comparison to their non-Medi-Cal lines of business to understand how access is or isn't different between Medi-Cal and non-Medi-Cal lines of business. That assessment will be informed by an independent access advisory committee. And so we have currently out there applications for people to submit to us if they would like to participate in that committee. And then as soon as these bills get through and everything, we will have that committee start up and the EQRO start up to work on the design of the access assessment. The committee will inform not only the design and the structure of the assessment, but also will review drafts of the assessment before it's finalized. So I think you've probably heard a lot from me, so I will go ahead and stop there.